Global health equity. The role of AI in bridging healthcare gaps.
Okay, great. Thanks for getting up early after a night out in Malta, if you've arrived here. Very welcome. My name's Keith, and I'm delighted to be here today with a brilliant panel to talk on another important topic. And you'll have had a lot of important topics covered here about global health equity and the role of artificial intelligence in bridging those healthcare gaps. AI is a huge topic, doubtless. It does help to define some things. So let's ground ourselves first by saying, well, what are we talking about when we talk about global health equity? So back in 2015, the United Nations published their 17 sustainability goals for 2030 with some aspirations for where we should be in the world by 2030. And across all of them, and there are many, Goal 3 looks specifically at health, and there are some targets within each of those, looking at maternal and child health, communicable disease, non-communicable disease, the impact of the environment, and so on. But there's one goal within that I think captures it really well, and that's Goal 3.8, which is about universal health coverage. It's the ability for people to be able to access the healthcare that they need in an affordable way around the world, and the aspiration by 2030 is to have everyone have access to this now. I don't think people would want to argue too much with that. So the question is, how are we doing? There's an index back, looking from 2000, the index was around about 45, and then most recently it's up to 68, and you think, well, that's some good progress. But here's the thing, from 2015 to 2019, and then from 2019 to now, it has moved very little. And in fact, in some areas, it's gone backwards. More people are being driven into poverty as a result of their healthcare expenses, and this is being disproportionately felt in low and middle income countries. So we do definitely have a problem. And when we're talking about equity, we're not talking about equality with everyone having exactly the same things. This is about making sure that this is fairly distributed among those groups, particularly those who may have some other disadvantages as well. So to that end, I'm delighted to bring together this brilliant panel. And I'm going to get them to speak a little bit in a wee moment about themselves. My name's Keith from Curistica. I'm a GP by background. I deliver fractional chief medical products and clinical safety officer services to health tech companies. We're very interested in AI, but ultimately, we love building safe and effective products to help patients. And I'm sure a lot of people here feel the same way about this too. But next to me, we have first Hansa Bhargava. She's from Atlanta in the US, medical doctor, pediatrician by background, former CMO of Medscape, and currently chief strategy officer at Helio. And then next we have Ilya. Ilya is from Austria, a medical doctor himself, specializing in medical AI development back from 2013, formerly from Accenture with some great successes there. And he has for the past 6 years been running an AI consultancy focusing on creating trustworthy medical AI, which is delivering 100% accurate, hallucination-free. That's interesting. This is maybe for another topic, but that's a good one to go into it. Then we have next Tashi Gelson. He's from the Human-Centered AI Research Centre at Swansea University in Wales, and he's working with academics and businesses to create new forms of AI technology that address real-world problems, including health. And then finally, at the far end, we have Mihir. He's from the US, from Indiana, and he's a practicing orthopedic surgeon, and he's a partner at Lead and co-founder of WellCourse. So the panel here, you want to say welcome to the panel? Great. Okay, so we have a short period of time, a small problem to try and solve, but let's try and tie it in. I like to think about this as like, well, what's the potential of artificial intelligence first? Let's start on the upside. So, yeah, if we're talking about the potential for AI to be able to address this problem, what do you think the potential is? Who would like to maybe start? Tashi, you're sort of bouncing there, so you're a good man to go to start with.
Hello. Yes. I think in the sort of medical domain, we have this sort of care pathways, life cycles of preventative care, diagnostics, treatment, and drug discovery, all that. Where AI can have the most powerful effect in addressing equity is diagnostics, in my view. And that's because with the use of deep learning techniques or machine learning techniques, you can look at these sort of symptoms biomarkers, put it in the cloud, and have a very quick sort of diagnostics that sort of prevents and sort of bigger diseases and catches them in time. So, for example, in our Human-Centered AI Research Center, where we work very closely with clinicians to develop these models, the latest example I can give you on this is we have a doctor called Bilal Sharif and a colleague from chemistry working on a new AI model that can be put in the cloud and develop new kinds of kits, small, scalable, low-cost kits that can be taken to the deep areas of resource-constrained communities, working with doctors in Delhi itself, so we don't discriminate on the sort of local data sets, local issues. So combining all that, we've developed this deep learning techniques that can be in the cloud and basically taking the hospital to the communities and where communities can't go to the doctors. So yes, in the space of diagnostics, AI really has that amazing power to help address the equity.
Yeah, so this is talking about using the power of AI to deliver high-quality diagnostics in a way that can be delivered to different areas as well. And you're talking about one of the sort of middle-income countries there and low-resource settings. So that's maybe a really good example to start with. And Ilya, actually, I think when we were speaking before this was one of the themes that you really strongly believed in with artificial intelligence, about that sharing.
Absolutely, and bridging what Tashi said, what I'm really excited about in these times we have now, as a medical doctor, I know the medical domain, what we need, how to solve these issues. And I'm really excited as a developer, I see how big the open source development is. Open source means that everybody has access to the source code of the application. And why I'm talking about this is because technology is not like a big disadvantage anymore. If you have very cheap access to it, which means everybody, if he uses like ChatGPT to find out how he can use these models, I mean not on the LLMs, but everything else. And this is something really exciting, like also talking about diagnostics. For example, in South Africa or India, there are many researchers for cancer, the diagnosis, and through open source, if they open source the code, they can collaborate with all the other people in the world and specify on the needs in these areas. And this is something a collaboration was not possible before, and even especially in AI. And if I talk about this, if we talked previously, like people say, oh, if it's open source, it must be expensive because I need to run like this ChatGPT. It must cost huge amounts of servers. And that's a huge misconception. It's not true. You can run it on your smartphone, and there are a lot of examples. And that's why make a point, a statement that you can do this, that you can have AI, which open source. You first need to democratize the knowledge. If you have the knowledge, then you have the data. No quality data, no AI. So first the data, and then you have more equity in access to patients, better patient treatment and care, and then you will have a better advantage to achieve more health equity.
Yeah, and this is how technology, it sounds like these technologies that are very broadly available can then improve access, and then it's delivering the sort of intelligence more broadly as well. So yeah, very, very powerful things. And even this morning I was seeing that people are developing small models, types of technology that can run on very small devices, like a Raspberry Pi type device, a very small, cheap cost computer that can do very effective things.
It's even more accurate because if a big model, it answers everything but not precise, and small models are even better, yeah?
Yeah, a little specialist knowledge there as well. But so you're developing, this is about the technology, but we also need to understand more about how the practice is undertaken in that area. And Hansa, we spoke before as well about this, about the importance of involving the patients, the clinicians, the ultimate end users.
Yeah, so I think that AI has so much potential, but we do have to understand who is the end user. And the end user could be the patient or the layperson, or it could be the clinician or the nurse. And interestingly, I think that equity, like AI, can be such an important tool with equity because there's a report that came out in JAMA, actually, the Journal of the American Medical Association, recently, which said 80% of ERs in the United States actually don't know how to manage pediatric emergencies. Well, I'm a pediatrician, and what does that mean exactly? Going back to what we said about diagnostics and helping diagnostics, can AI actually help diagnose those kids that come in through the ER? I mean, I don't know how many parents are sitting here, but I'm a parent too, as well as a pediatrician, but I don't want to take my child to an ER that's an adult ER that can't manage my sick child. So if AI can actually help, you know, equity in terms of access to quality care in those ERs that don't really know, that can help. Like, it can actually help access to care for so many people.
Yeah. And I suppose that expert knowledge, when you look at the UN Sustainability Goals in the health domain, the first two are maternal and child health. So there's this gap in pediatric technology, or PedTech, and this is really powerful. But getting that expert knowledge is out there, but do you think it's fair to say that the expert knowledge developed in the US would be applicable in other areas? I mean, I suppose this is where the local user engagement is so important.
Yeah, and I think that's where definitely, I think the user engagement is super important, and clinicians, doctors, and nurses understanding, again, end user understanding the fundamentals of AI is super important, because the user have to understand that data diversity is super important. So can an algorithm from New York City actually work on, you know, the rural population in the UK? Not so sure, right? Because the data is based on certain segments of population. That's not necessarily true of all of the populations, but having that fundamental knowledge is super important, so you understand it.
I mean, it's no different to the fact that I'm a UK-based general practitioner. Were I to practice in the US or India or sub-Saharan Africa, you would rightly expect me to understand more about that population too. Artificial intelligence, no different. Now, Mahir, I'll come to you in a second, but Tashi,
Yes.
it looks like you want to come in on something.
Yes, I completely agree with Hansa. Coming from a human-centered AI research center where we really push the approach of absolutely working with not just the clinicians, not just the the administrators, but absolutely patients, users at the center of the whole AI design. And only by doing that, and it's not a gimmick thing either, it's just a one-off participation. They have to be involved throughout the stages of AI development, reiterative designs. Only then we can have an AI solution that is trustworthy, that is transparent, and a huge adaptability.
Yeah, this is not just a box that you need to tick or do once. You have to commit to this and keep going. So we're talking about the patients and the clinicians, but Mahir, when we spoke before, I was really fascinated to hear about your example of using AI. Healthcare is not just patients and doctors and nurses. There is a huge number of non-clinical staff working, and you've had some successes there.
Yeah, we've been working with AI for 2 years now with ChatGPT, and in our practice, healthcare in the U.S., we put some of the least educated people on the front lines who are answering the phones, taking the messages to relay to us. And what we found in our practice that putting AI, the AI tools in their hands actually raised the floor. Like, they basically thanked us for the ability to sound intelligent when the phone calls came in, and we were happy about that. But one of the greatest efficiencies we saw, and AI is one of those things where for us we don't necessarily know everything, and what we found was that afterwards our people who were using the AI versus those that weren't, the queue times in the phone calls became a lot less for those who were using AI. And it was strictly because they didn't have to type in the messages into our EMR. All they had to do was cut and paste. And once they start cutting and pasting, the queue just goes down. And they send it to us, and then we can answer. And so for us, that was like one of the greatest efficiencies. And you can get more phone calls in terms of their metrics.
Yeah, and the thing I love about this story as well is that when people think about AI and medicine, maybe, or healthcare, they very often focus on, well, the clinician or the diagnosis. I often speak to people about this. When you're dealing with any of these problems, you're often best looking, well, what's next to the problem? What's beside the problem? Because when you look at the first problem, it's like the center of a target. But around it, all these supporting services and all these things that aren't immediately thought of as clinical directly impact on that too. And the example that you gave is a great one there. So this is all great. AI is going to solve it all, okay, obviously. But we're not here just to sort of say wonderful things. We're also to say, well, it's not all upside. There is a downside. So let's look at some of the pitfalls here as well. These are some success stories, but what do you think some of the pitfalls or challenges that might come along the way that will stop AI being used safely and effectively to address these gaps? What does anyone think on that? Oh, Ilias first, then we'll come to Hansa.
I think it's very good what you said about data. I think you have to include the physicians and the healthcare staff very early in the product, not afterwards. And that's seeing as in different industries in healthcare, it happens quite often that you include this relevant stakeholders like patients and doctors much too late. And talking about AI, if you have like data from the US and you don't know if you're sure if you can use it in Europe, it's like we need diversity. We need to include all minority groups in different countries. But if you're not so sure if it's working or not, if there are quite a lot of tools and usage available to find out is there lack of diversity and is there like a misconception. You can, for example, you can use LLMs to make t-tests and see if you have one diagnosis and two different demographics. You can run a t-test and find out, oh, would it be treated differently or not, and why? And this is something we need to focus really early, and this could be a pitfall if you don't do it, if you don't include the doctors, and you trust the AI, everything. And that's the reason why I say you need to develop an accurate, not 100% is a goal which you never reach, but it should be about 98, 99, and to achieve that, you need to combine LLMs with a different technology. LLM alone, a large language model is not enough, and you have to include the doctors very early in the process in the product development.
Do you mind if I jump in? So I think I totally agree with you. The reason I include doctors or nurses or clinicians early in the process is because you're going to have a better product if you're working with someone at the front lines who has actually walked the walk, right? So that's number one. Number two, workflow integration. At the end of the day, when you've developed the product, you've got all your funding, and now you're like, okay, hospital, take it. That workflow integration needs to be seamless, otherwise the doctors are simply not going to use it. And number three, safety and outcomes. Like if there's several cases about this, right? In the NHS where they had an algorithm where they were trying to make the flow of the clinic more efficient by finding slots where patients could be stacked up on each other. That was a great example because what the algorithm ended up doing was actually stacking up people who couldn't come, who were more likely to miss the visits, who happened to be from a certain population. So that was inequitable because those patients were being punished for actually being from a certain poor population, whatever population it was, whereas the other patients were actually given more slots. So that algorithm went off the rails. Now, if the doctors and nurses don't know about the algorithms, they don't understand it because they weren't part of the product from the very beginning, then they're not going to be able to say, oh, this went off the rails. And there's so many examples of that. So 3 reasons is better product, better workflow integration, and lastly, safety and outcomes.
Yeah. I told you this is a very broad subject. Mihir.
Yeah, I think that the common element is that with AI, the best things that we see in terms of outcomes is if there's a human reviewing what's suggested. And so think of seeing a physician, people to come see me, and it's more of a suggestion. I'm a resource. Think of it as a resource, not the end all. And I think that will be the most effective use of this, because ultimately we still can process better than anybody else or any computer at this point in time, based on where AI is at this point.
Mm-hmm. Yeah, I just wanted to say, so we're talking about these things as potential pitfalls, and Tashi, I'll come back to you here in a moment about the involvement of the non-clinical stakeholders as well, because again, I think that's such an important part. And when we speak of patients as well, of course, think of carers to those people providing care, because when it comes down to it, if a person is ill, they are less likely to be able to access these technologies. The people around them have to provide it too, be that parents or carers too. So this is a big group that we have to think about bringing in. Tashi?
Yes, just to jump back on Ilya's point. I don't like the sort of made in California approach where clever AI models are tested, designed, all in the resource-rich regions, and then trying to deploy it or even adapt it in a resource-constrained communities. I think we are getting into that mentality, which is very problematic in my view. That's because we all know without data sets or data, AI is just a useless tool. So for example, when we tried that sort of made in California approach and using it in the resource-constrained communities, the performance will suffer badly. And I'm not just talking about performance. It then leads to trust, the trust erosion in people in those sort of less resource countries. And by doing that, there is a danger of misinformation, disinformation, when people in those resource-constrained communities are very much used to doctor-patient relationship, and AI comes along, misdiagnosis because it comes from the West. That is a huge problematic issue, I think.
Oh, absolutely. And you know, there's a number of papers. Actually, after this, we're going to be having a further conversation. I'll share a little summary of this on LinkedIn too and reference any of these papers. But the other thing about the kind of made in the West, sent elsewhere, is that that deprives the West of the innovation from low and middle income countries. And you know, time and again, examples of innovation in frugal settings are highlighted that would transform how we deliver care in notionally high resource settings as well. So this is not just for us to step in and help. We can be helped otherwise. So this flow to and fro is to everyone's benefit as well, I think.
100%.
Yeah. So we've talked about the potential of AI, and we've hinted at some of the pitfalls in here. But the trouble when talking about artificial intelligence, because it's such a broad subject that's constantly moving, is it can be difficult to start thinking, well, what can I do? And none of this is going to work if we're just passive recipients of what is pushed out to us. Now, we've got nice people doing this, and that's all great, but we have to be active. So what I want the panelists to do as we start coming towards the end of this time is sort of maybe share what you think would be a practical takeaway thing that either you are doing or the people in the audience might want to do, so they can start using AI or any technologies to help close this global health equity gap. So anyone have any thoughts on what should they be doing? We want to step forward.
So I think with AI and all the algorithms out there, what I found was, asking it 2 to 3 times, and then getting those answers, and then seeing what it answers. And so that's a great way to test it, as opposed to just asking it once. And for us, that ended up being a better data set to make decisions from. And what was truly exciting is that, like, we're in the West, and yeah, it's very West-centric, but to be able to basically get information from somewhere in the middle of a small town in India that ends up in that data set is actually truly exciting going forward. And that will actually make us all better at the end of the day. We don't have to go seek out that information, because it's sort of putting it all together. And the funny thing is, it's my front office people that told me, like, if I ask it 3 times, they're the ones that came up with this. I was like, that is like a brilliant idea. So I think just asking a couple of times, you get a great idea and you get going.
That's it. It's just, we just listen to our diversity of inputs, the benefit of involving these stakeholders and solving these solutions. The solutions come back the way. Ilya?
I think implementing AI, which is equitable in healthcare, is like developing a website. I think we have a lot of business owners and people in marketing here, and if you develop a website, no website is ever finished on time. It's never like you want to have it. And that's why? Because you need to understand, what do I want? How do I communicate it? That's the same with AI. If we want to, as I said, and all the other agree, that we need to really early get the stakeholders on board, and they need to understand what's the technology capable of. Just not in the detail, they don't need to code, but if you understand what they're capable of, then they can much better communicate how the product should be designed to close this healthcare equity gap, and then we have a much better product. So just a little bit more involvement into understanding how the AI really works. Yeah? This would help the gap.
So for people to understand the AI, once again, involve the end users and the stakeholders as well. Tashi?
Thank you. I think true health equity in AI can only be achieved, in my view, is when the resource-constrained community take ownership of their own future. Now, and I'm saying this because when we talk about AI, again, I emphasize AI is nothing without data sets. So it's absolutely crucial for long-term stability and sustainability is that we create your own data sets in those resource-constrained communities. You could look at using NLP to extract current data, or use the health workers network to collect data. When you have your own data, you have the absolute accuracy, trust, and building all that. But excuse me. One last thing I want to point out is we need to sort of, in the theme of ownership, I think it's important that we develop local capacity, not just for the doctors, not just for the users, not just for the health workers, but everybody to involve, and you start using AI wherever they are.
Yeah. And Hansa?
I would just say the same as my colleagues here. Data diversity is very important, making sure everyone's represented, and also end user engagement.
Fantastic. So there you go, everyone. You've got your instructions. You know what to do. We're all here for a reason to try and help patients and improve global equity. I want you to thank my wonderful panel, and yeah, enjoy the rest of the show.